My name's Dr. Chhabra. I think I've pretty much met all of you throughout my time here since I've said September. So I came here in September as the new stroke director. So as you guys have probably noticed, I've changed a good amount on how we treat acute ischemic stroke, how we do the stroke workup, and how we treat patients with secondary stroke prevention. So I kind of wanted to give you guys a talk on the recent advancements in stroke care, not only in the acute side, but also in the prevention side as well. And also give you a little primer, so when you're overnight and you may not want to call us, or it's 3 in the morning, or we don't pick up because we're sleeping in the middle of REM. After this is over, we're going to bridge this version into like 3 or 4 slides. So when you're on call overnight and you admit a stroke patient, just a quick basic idea of what to do in that first 12 to 24 hours, and then also how we can handle inpatient code neuros. And I subtitled it "No Longer Diagnose and Adios," because some of the older people in the crowd might remember that the old mantra for neurologists was that they come, they diagnose, and they say adios, because there's really nothing they can do, right? But that's changed so much the past 20 years, and there's been a huge paradigm shift. So not only with stroke, but also with MS, epilepsy, Parkinson's, there's so much more we can do now for our patients. So it really is no longer diagnose and adios, as you'll see, at least from the strokes aspect in this talk. So, 1998 was the big TPA trials, and after that we realized, okay, we can actually do something for these stroke patients once they get to the hospital. We can do IV TPA. At that time it was within 3 hours, now they've extended it to 4.5 hours. So it was a big push to get patients to the hospital quicker, evaluate them, and be able to do TPA. And that's how things were for 15, 20 years. And in 2015 was another huge shift in stroke care with the advent of interventional procedures that have shown to be beneficial to improve morbidity and mortality in these stroke patients, specifically the ones with large vessel strokes, and for lack of a better term, the bigger strokes, the ones with a high NIH greater than 10 or 12. So in 2015, it was kind of like a rapid domino effect. These 5 trials came out. The first one was Mr. Clean in Netherlands, and then literally, they ended early actually because they already saw a benefit. And everybody talks, so once the word came out that they were going to publish positive results, everyone ended their trials early. And within the span of 6 months, you had 5 positive trials that showed the benefit of taking patients with large vessel occlusions, those occlusions being in the internal carotid artery, middle cerebral artery, and basilar artery, taking them to intervention within 6 hours of symptom onset if there was a demonstrable mismatch on CT or MRI. And just briefly, I'm not going to delve into this too much, but briefly, just you can see the results of the data from the study. All the trials use 2 things. They use something to look for the vessel image, or an image to look at the vessels, whether that be CTA or MRA. And they also had objective findings to look at if there was a mismatch and if there was tissue to be saved. So if you can see, they use aspect score. And I know that's a little bit out of the realm of this talk, but basically what that does on non-con CT, you can kind of delineate whether there's infarcted tissue already. And the infarcted tissue will be tissue that you can't save. So they all either looked at aspect score or some modality of CT perfusion if it was accessible. But in a lot of the smaller community hospitals, it's not accessible. As it is here, we don't have CT perfusion. So that's why they end up using aspects to be able to enroll more patients. But you can see, in terms of the time windows, they all range from about 4.5 to 12 hours in the different studies. And they weren't saying that we shouldn't do IV TPA. We still have to do IV TPA, but you do the interventional and the thrombectomies in addition to the IV TPA. The baseline NIH was about 15 or 16. So these are pretty big, debilitating strokes that these patients are going to have. It's not really necessarily going to be the minor strokes. And the outcome they looked at was improvement in MRS function, which is a function we use, modified Rankin scale, that we use to look at outcome. And they only really enrolled patients if their MRS was 0 to 2. So that's another thing to keep in mind, is that for these interventions, if someone already has a long-standing history of dementia, someone takes care of all their ADLs, they never enroll those types of patients. So, sometimes I'll still take patients for angio and for intervention, but it's not necessarily indicated. So that's another thing to keep in mind as well, because they only took those patients with an MRS of 0 to 2, and because the outcomes they looked at were MRS of 0 to 2 at 90 days. And so what did I do when I came here to Mary Washington? So in September, the protocol in the ER and on the floors too for the inpatient code neuros was patient with acute neurosymptoms, CT brain, and then evaluation by a neurologist, decide whether to do TPA. And then once the neurologist sees the patient, then we decide, oh, do we need a CTA or not? And granted, this was how things were done for many, many years. And around 2015, when things started changing around the country, we were a little behind the times. And as you can imagine, using that algorithm that I just mentioned, you're not going to get the CTA to look for large vessel occlusions on patients in the ER for like 2-3 hours down the road. You're wasting so much time. So the first thing I did when I came here is that every code neuro that the ER calls, and I'll get to this with you guys with the inpatient code neuros as well, it's an automatic CT-CTA, head and neck, okay? Because we want to look at the carotids as well. And it might delay us 10 minutes to giving TPA, but the information we get from it is far, far more beneficial. And if someone does have a large vessel occlusion, you're getting that information a couple hours earlier, and you can transfer them a couple hours earlier. And as you guys all know, time is brain in neurology. Versus if there's no large vessel occlusion and you were delayed 10 minutes on TPA, okay, you delayed them 10 minutes, but they'll still do pretty well, because the fact that they don't have a large vessel occlusion, they probably didn't have many symptoms to begin with, so you're still kind of okay. So it's kind of one of those things where the risks, you do like a risk-benefit analysis, and everywhere around the country they're doing CT-CTA for code neuros within 6 hours of symptom onset. So that's the first thing I did when I came here. Now, you guys have seen all on the floors. You come in the morning, or you get a page from nursing overnight. Yeah, this patient has new neurological symptoms at 8 or 9 a.m. And then we talk about, well, when's the last time they were normal? It's the night before. The predominant portion of strokes that we see occur between 3 a.m. and 7 a.m., and that's based on epidemiological data. And it's because of the dynamics in the body when we sleep, whether it's due to low blood pressure, stasis of blood, clot formation. But we know that the greater portion of strokes occur between 3 a.m. and 7 a.m., specifically the large vessel strokes. So what do we do with these patients that come in the ER or that wake up on the floors? Their last known well is 10, 11 at night, and it's now 7 a.m., 8 a.m. So what I did with the ER is I implemented a wake-up stroke protocol. So what that means is, regardless of when the patient went to sleep, if they woke up with symptoms greater than 6 hours, then we do this wake-up stroke protocol. Okay, and this was a really good case. Actually, we started this around November. It was a really good case. It was a 56-year-old female with a past medical hypertension, diabetes. She went to bed at 10 p.m. the night before, and she woke up at like 4 or 5 a.m. and with right-sided weakness and difficulty speaking. And she what ended up happening was she ended up having a fall out of bed, and then her husband woke up and saw her and saw she was unable to speak, and she wasn't moving her right side. They brought her in at 5:36. So if you look at the time, you're already at 7.5 hours. So the guidelines now for the interventions are up to 6 hours, right? So she's already out the window. So traditionally what we would do 5 years ago, okay, they woke up with symptoms, nothing we can do, admit, conservative management. Nowadays, you're still technically in the right to say that, okay, it's greater than 6 hours. There's no indications for taking them for intervention this late, so still admit to the floor for conservative management. But I like to be a little more aggressive, as you guys may or may not know, and I like to try to do as much as we can for our patients. So with implementing MRI wake-up stroke protocols, what it does, it gets a DWI sequence on the left, a flare sequence in the middle, and it does an MRA. So the MRA, you can obviously see the carotid is out, right? There's no carotid, there's no MCA. But we don't necessarily know when her stroke occurred. Now, flare is a good indicator of infarct, and you can match it up pretty well with hypodensity on CT scans. And strokes usually take, on average, about 6 hours to become bright on flare. DWI changes will be immediate. well, 15, 20 minutes, but for lack of a better term, they're going to be immediate. So using DWI and FLAIR and comparing them, we can find a penumbra and look for a possible mismatch. So two things we can do in this patient. So one is we look, okay, her entire carotid's out. That's is supplying her left MCA and her left ACA. If you see here, she's getting good bilateral ACA flow, so she probably has her predominant ACA flow coming from her right A1, right ACOM. So that's fine. That's a normal variant. Okay, so maybe she won't lose her ACA on the left. But there's so much more territory here that's not even ischemic yet. There's this territory that's ischemic, in the basal ganglia, a little bit of the insula on DWI, but there's not even flare changes. So for two reasons, this stroke probably occurred. Well, the first reason, for number one, the stroke probably occurred less than 6 hours ago because there's no change on flare and you already have DWI positivity. Number two is that looking at the vessel that's occluded, the carotid, you would expect a carotid occlusion to cause so much more damage as to what it's causing right now. So that tells me that there's more damage to be had. So not only is there an area of penumbra here, but there's a greater area of territory that's at risk. So for this patient, we sent them over to VCU for thrombectomy. She had a thrombectomy and she did really well actually after. So this is one of the good cases where they get sent over, they do the thrombectomy in time. I would say her stroke probably occurred like around 3 a.m. I can't say for certain, but kind of based off using my experience and basing off what I see on the scans and her exam, it probably occurred around 3 a.m. I'm guessing. So why is that important for you guys? And that's the inpatient code neuro process. So we've worked a little over the past year to fine tool the inpatient code neuro order set and how things should work. So for you guys, this is how the process should go, okay? So whatever time of day, whether it's in the middle of the night or if it's early in the morning, you get a page from nursing about acute neurosymptoms or a change in neurostatus. The first thing that you guys should be doing is first ask them when did the symptoms start, or more specifically, when was the last known well. And the nurses, you guys should try to communicate that to the doctors as well and just kind of already have that in mind. And it's important because now as the hospitalists, you guys will be writing the inpatient code neuro order set. Now I think we've been working with the sound group to have the code blue hospitalist, I believe, and you guys can correct me if I'm wrong, the code blue hospitalist is going to cover the inpatient code neuros when the neurologist isn't in-house, like overnight and odd hours. So what will actually happen is, if it's during the day, the nurse will page whoever is the physician that's responsible for seeing that patient. That physician will decide, was this a wake-up stroke? Or is the last known well less than 4.5 hours? Is the last known well less than 6 hours? Based upon that, our treatment modality is going to be different, right? Because if it's a wake-up, we want to do the MRI wake-up stroke protocol. If it's last known well less than 4.5 hours, they can still get TPA. If it's last known well less than 6 hours, if it's between 4.5 and 6 hours, they can't necessarily get TPA, but they could get a CT-CTA, which will be quicker than an MRI wake-up stroke protocol. If there's large vessel occlusion, then we can transfer them for intervention, okay? So, when you get the page from nursing, try and think in your head which one of those three the patient falls under, and based upon that, order the appropriate imaging test. And then once that's done, and that'll be part of the order set. So you hear the symptoms, then you go and you type the inpatient code neuro order set. You decide, are we going to do the CT-CTA, or do we just not check the CT-CTA and we just go straight to MR because it's a wake-up stroke? And then and then tell the nurse to call the inpatient code neuro. Once the inpatient code neuro is called, the MSET nurse will respond. As I mentioned, if it's off hours, overnight or off hours, the code blue hospitalist will respond. If it's during the day, the neurologist in-house will respond. But if it's off hours, the code blue hospitalist will respond and the neurologist will respond via phone. And then usually what I will do is, in conjunction with the MSET nurse and the code blue hospitalist, get an idea of the exam and kind of what's going on. And if need be, I will evaluate the patient, or whoever's on call will evaluate the patient through the robot that we have. It's just basically just a camera on wheels down in the ER. And the MSET nurses know about this. So, I hear the exam they do. I'll talk to the Code Blue hospitals, kind of see what's been going on. And then I decide, okay, after the scan, since the scan's already in the first floor anyway, send them to ER room, I think 27 it is. They'll have the robot in there, and I'll take a look at the patient and evaluate them and see what we want to do, okay? And, I know you guys are busy overnight and things get pretty hectic and crazy, so, if you guys aren't able to respond, that's okay. If you're available and free, it'd be great if you could respond, because it's nice to have a physician lay eyes on the patient who kind of maybe knows a little bit more what's been going on in the hospital. You guys are more aware about contraindications and recent surgeries and things like that. So that's kind of how we should be doing it. I just put a picture of, this is going to be like a right MCA occlusion, and this is after recanalization. This is another patient we sent over to VCU. They usually just send me all the images there after the cases are done, and I kind of follow up with them. So the second thing, the first thing that I want you guys kind of get out of this talk is the inpatient code neuro process. Do you guys have any questions on that? Okay, so the second thing is inpatient medical management post-stroke. So this is the kind of late evening, overnight stuff that I want you guys to start trying to do when we're not around, and you don't necessarily want to bother us. Now, that being said, when I'm on call, you can bother me whenever you want, okay? I don't mind getting called at 2, 3 a.m. if you have a question. Doesn't matter. Because I'd rather deal with the problems then as opposed to coming in at 8 a.m. and realizing, oh, they completed their stroke or so on and so forth. So feel free to call me whenever. And also feel free to call me if you think the ED is admitting a patient that you doesn't think need to be admitted, because I've blocked a lot of those from the ED, okay? So just always remember that, and you can call me whenever. But inpatient medical management post-stroke, the three things that I'm implementing, and these should be reflected in the order sets coming up, are going to be permissive hypertension, specifically avoiding hypotension, head-to-bed flat, and IV fluids. Just 2 days ago, me and Sunita had a patient. She came in, and there's another great importance of CTA, is that her CT was clean. She came in with right leg weakness, greater than right arm weakness, and a little bit of aphasia. And her symptoms resolved, but she still had a little bit of right leg weakness by the time she came in, maybe subtly weak in the right arm, a little bit of language difficulty. The CTA actually showed a A3, a third branch of the ACA on the left side, stenosis versus thrombosis. Because of that CTA, and because her symptoms were fluctuating, I knew that there was a tight lesion there, that permissive hypertension was really, really going to be important for her, okay? So, we should be doing permissive hypertension in any stroke and TIA patient, but specifically for that one, I made it a point. I talked to Sunita, I talked to Rohit, the ICU attending, talked to the nurses, make sure that her blood pressure stays high. And it's funny because she came in at 130, 140 systolic. Every 15, 20 minutes, it crept up to 150, 160, 170, 180. By the time I saw her, she was 190s over 110. And her right arm symptoms were gone. She was following commands, able to speak. Her right leg was still weak. So at that time, I figured that her blood pressure is high, her body's compensating to increase perfusion to her brain. That's why we're saving her right arm and her language right now. Let's keep permissive. I kind of gave up on the right leg. I was like, okay, she's going to stroke, and it's fine. She'll have a right leg stroke, or stroke in her right leg. That's okay. I don't want her language and her right arm to be affected. So we did permissive hypertension overnight. She looked dry. I told the ED to give a bolus of fluids and then 100 cc's an hour. So IV fluids are very important in stroke patients because one big risk factor for stroke is dehydration. You might notice when the weather's hot, 90s, 100 degrees. In UCLA, we saw this a lot. Patients came in from the desert and they'd have strokes all the time, during those hot summer days. So fluids are super important. So we pumped her up with fluids. We did head-to-bed flat overnight. And actually the next morning, her right leg weakness was gone. And she was basically at her baseline. And her MRI showed a tiny, tiny punctate area of infarct. So that's just, not all cases are going to be like that, but it just stresses the importance of permissive hypertension in someone like this. Now, I think overnight for you guys, use your best judgment. A lot of patients are just kind of admitted as quote unquote TIA with just dizziness, whole body numbness, things like that. I mean, you are syncope. You guys know just as well as me that those probably aren't TIAs. TIAs, if it's going to be dizziness, it's going to be vertigo, really bad, intense vertigo, not necessarily just regular dizziness and lightheadedness. Same with syncope. So if you're overnight and you see someone coming with a true TIA, and a true TIA mean like focal weakness, transient left arm, left leg weakness, facial droop, slurred speech. If it's just slurred speech alone, that's kind of another neither here nor there. I've seen a lot of patients with slurred speech. Most likely that's going to be toxic metabolic. But if it's slurred speech with a facial droop, with weakness on one side, numbness, tingling on one side, or if you think that it's only slurred speech, but you're pretty confident that it was a TIA the way it sounds, I'm okay with that. But we should really get them permissive hypertension up to 220 systolic, okay? And of course, if they get TPA, we can only go up to 180 systolic, but usually you guys don't have to worry about that because they go to the ICU and I just deal with it with the ICU attending. But whenever you're admitting a TIA or a stroke patient, permissive hypertension up to 220 systolic. And another important thing is don't check box to continue their blood pressure meds. Because I've seen that before also where the blood pressure meds are just continued overnight and they come in and they complete their stroke, okay? So not only do we do permissive hypertension to not treat with IV meds, but you don't want to give them PO meds and you want to pump them with fluids, do head to bed flat. Just overnight, and then when I come in the morning or one of the other colleagues comes in the morning, we'll tell you, be like, okay, no more permissive, or we'll talk to the nursing staff. They're kind of out of that window. Typically, we only do it up to 24 hours, and then as you see in the bottom, we'll liberalize the BP goal, and then we'll complete the stroke workup. For IV treatment of blood pressure over 220, labetalol and cardine are the only ones that should really be used. Hydralazine can really significantly lower blood pressure, and it can cause strokes from that low blood pressure, cause worsening of a stroke deficit. And then, of course, if they didn't get TPA, antiplatelet, DVT prophylaxis, statin, and blood glucose control should be about between 140 and 180, or normal if they don't have diabetes. And I think we're all doing that anyways because they just get put on the protocol. Okay, so the next thing we do, so we have inpatient code neuros, we have this medical management within the first 12 to 24 hours with the permissive, IV fluids, head to bed flat. Then the next step we do as doctors, why do these patients get admitted to the hospital? Well, they get admitted to the hospital because we need to figure out why they had the stroke to prevent future strokes. So we try to look for the stroke etiology. I think our number one job as physicians should be looking for a cardioembolic source. Why? Because it's actually going to be a change in their management. Small vessel disease strokes are big too, but we don't necessarily change too much, and unless they haven't been on an aspirin or we want to do dual antiplatelet. We're still going to manage the risk factors: blood pressure, diabetes, cholesterol. It's great to say the stroke came from small vessel disease, but actually impacting their care. I mean, some patients are good about getting more educated and really being aggressive with their risk factor modifications, but as physicians, we can't really have as much impact as we do if we can diagnose cardioembolic source of stroke, because we can really prevent future strokes, and the cardioembolic strokes are the future debilitating ones. Large artery athero is the third type of etiology. So your main three etiologies are going to be cardioembolic, small vessel disease, large artery athero. This is going to be your carotid, your intracranial athero, vertebral basilar disease, things like that. And then we have cryptogenic and other causes. I'll have like one slide on those. For you guys and for the purposes of this talk, that's not important. I mean, those things are my job to figure out why this patient had a stroke. So cardioembolic. So here are just a couple examples of cardioembolic appearing strokes. You can see they're always going to be cortical. Okay, 29% of ischemic stroke patients are going to be cardioembolic in nature. And that number is actually rising with the advent of longer-term Holter monitoring, implantable loop recording, and just more awareness and detection of AFib in the community. As I mentioned, the locations are going to be cortical. That's going to be your outer rim of your brain, the gray matter areas. They're going to be bilateral, and it's important to know that the cortex can involve the cerebrum and the cerebellum. And they're going to be in different vascular distributions. Okay, so you see all these examples I put up here, they're all cortical. They're all kind of in the outer parts of the brain. Same thing here, 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 and here, okay? And in terms of risk factors for cardioembolic, I know you guys know this, it's AFib, AFib, AFib. Got to really dig deep to looking for AFib, okay? Valvular heart disease is another risk factor, whether they have a mechanical valve, endocarditis, infective or non-infective, and papillary fibrillostoma. It's actually a little more common than, I've seen it a little more often than I would think, and those patients usually get surgical resection. Cardiac thrombus, usually that's going to be from AFib, but sometimes in the left atrial appendage, you can have a thrombus without patient having AFib. Those need to be anticoagulated. Cardiomyopathy. You guys are probably aware of WARCEF and WATCH trials that were completed. They compared aspirin to warfarin in patients with low EF, and they found no benefit. But the important thing to note is that in that study, they did that for primary stroke prevention. So they didn't enroll patients that already had strokes, right? So I'm okay, and I never really anticoagulate in patients that have a low EF. But if they have a stroke with a low EF, then I anticoagulate. Because in those studies, they never enroll those patients, okay? And atrial myxoma is another kind of zebra cause of cardioembolic stroke. Aortic arch atheroma is another, we see it every now and then in terms of a cause for stroke. It stresses the importance of getting a TEE, because that can really look at the aortic arch, and I'll talk a little bit later about how we manage aortic arch atheromas. So small vessel disease is the second subclass. These are going to be your tiny basal ganglia strokes. 23% of ischemic stroke patients have this. These are subcortical infarcts that result from occlusion of a single penetrating artery, your lacunar striates from the MCA, your thalamoperforators, your pontine perforators. And because of that, the locations are going to be the basal ganglia, which is going to be your caudate, putamen, thalamus, internal capsule, corona radiata, pons, cerebellum, the white matter portion of the cerebellum. So here you can see this is probably either internal capsular lateral thalamic stroke right here. Here is probably also a lateral thalamic stroke, and you can see an old stroke here in the internal capsule. So these are just kind of some of the locations where you'll see small vessel disease. So, and the capsular warning syndrome. So these patients will actually have these, what we call stuttering TIAs. So they'll have, full side hemiplegia, full hemiplegia on one side, or numbness, tingling on one side, and then it'll get better. And it'll come back again, it'll creep, 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 then it'll get better. And those are that's the capsular warning sign. And those are important TIAs that you need to admit, do permissive hypertension, and manage them appropriately over that first 12 to 24 hours to make sure they don't complete their stroke. So that's a couple of the cases I've had when those patients get blood pressure meds, they're not really medically managed adequately, and they come in the morning and the next day and their stroke's completed. Whether that would have happened anyways, I don't know, but I think we should, physicians, at least do the best we can. So your risk factors are going to be the traditional hypertension, diabetes, hyperlipidemia, tobacco use, obesity, and it's important to know that in small vessel disease and large artery athero, I usually like the LDL below 70. And the AHA guidelines will tell you that in small vessel disease strokes and patients with atherosclerosis, you should get the LDL below 70, specifically if they've had CAD equivalent or diabetes, okay? But if it's a stroke from AFib, I'm okay with them just being LDL under 100, okay? There's still kind of some discrepancy in the field, and some people have their own opinions one way or the other. But that's usually what I like, and guidelines will kind of follow that as well. And OSA, obstructive sleep apnea, is another risk factor for small vessel disease. Specifically, as you guys know, OSA will increase blood pressure and so on and so forth. And blood pressure is the #1 risk factor for small vessel disease strokes. and I'm going to talk a little bit about blood pressure control and kind of what I like it as, and you guys can see if you agree or not. So large artery athero is the third type of thing we look for. It's about 15% of ischemic stroke patients. The main thing we evaluate for is extracranial carotid disease. On MRI, you can see strokes in the cortex, like here, and they're also in the watershed areas. So this is the MCA-PCA border zone area. And this patient had a right ICA stenosis. And you also see a pattern kind of like this. It's linear, higher up, kind of mid-cortical. It's pretty classic if you see enough of them, how carotid disease looks on MRI and CT. Intracranial athero is another cause of stroke. This is more common in the Asian population. You know, Caucasians will usually get AFib for their strokes. Asians will usually get intracranial athero. So it's really common in, you know, China, Japan, Korea, things like that. But intracranial athero can be in any location: ICA, MCA, ACA, PCA. It can be in the basilar and it can be in the verts. And remember, if there's basilar stenosis or clot that's causing symptoms, you can take them up to intervention up to 24 hours. Okay, and we did that with a patient a few weeks ago, actually. He actually had symptoms for 3 days, but he just kept getting worse and worse. So we still took him to transfer him to VCU for thrombectomy, and you know, he did well. He still has a pontine stroke, but he's not locked in. So aortic arch atheroma. So, you know, this is something that can be, some people put it under cardioembolic, some people put it under large artery athero. Whether you put it under one of those semantics, but I'll get into kind of how we can treat that. It's more rare than the other things that I've mentioned. And the risk factors are the same as small vessel disease: hypertension, diabetes, hyperlipidemia, tobacco abuse, obesity. You know, whenever I see small vessel disease or large artery athero on an MRI, I always educate these patients on 5 things. Blood pressure: do you have a blood pressure cuff at home? And is your goal 120/80? Diabetes: I say hemoglobin A1C 6.5. The guidelines will say 7.0, but I say 6.5 is because we know if the patients strive for 6.5, they probably will get to 7.0, if that makes sense. Statin, as I mentioned, or hyperlipidemia, go LDL less than 70. Smoking cessation education, and then antiplatelet. So I always tell them 5 things. It's kind of like my speech I give to all these patients. So cryptogenic, I'll just touch briefly on this. You know, 35% of ischemic stroke patients, this is numbers decreasing as the years go by with more discovery of AFib. I do my stroke in the young workup in someone less than 55. If they're 50 and they have really bad diabetes, horrible cholesterol, bad blood pressure, smoker, I don't do it. But if it's like less than 55, relatively healthy person, I'll give them hypertension, that's fine. But if they don't have any other risk factors, I do a stroke in the young workup. The main thing that we look for arterial ischemic stroke is going to be lupus anticoagulant, cardiolipin antibodies. The other stuff, you know, we test for it, but you know, you guys probably know it's more so venous clots that you get with those as opposed to arterial. But with the lupus anticoagulant, beta-2 glycoprotein, and cardiolipin antibodies, those are going to be arterial strokes. So I always at least test for those. And I think a lot of the stuff you can't even get inpatient here. They want you to follow up with heme. And I'm trying to work with administration on that. And I think when we get EPIC, I'm going to try and build a order set that's just a hypercoagulant order set, so we can just click it, order all these things. You don't have to think about it anymore. So we'll see if that comes to fruition. Dissection. So this is, I would say, the most common cause of stroke in people less than 50, whether it be the vertebral artery or carotid artery. You know, most commonly you see this with trauma, or I see this a lot with chiropractic manipulation in the neck. And you know, you can also see it with those connective tissue disease disorders, Ehlers-Danlos, Marfan's, OI, things like that. And it is the most common cause of stroke less than 50, so it's important to keep that in mind. And you always want to think about that. So if someone comes in with a stroke-like symptoms less than 50, ask them, have you seen a chiropractor lately? Were you in a car accident? I've had people do jujitsu, martial arts, things like that, and have carotid artery dissections or vertebral artery dissections. PFO. So this is kind of a hot topic in stroke nowadays, and the recent FDA just recently approved the PFO closure devices for ischemic stroke. Now, the main trial that we use is the RESPECT trial, and that actually did not show any significant difference in preventing ischemic stroke when patients got their PFO closed versus aspirin alone. So based upon that data, I still only recommend aspirin. Now, there was a subgroup in that study, and we always have to take this with a grain of salt when you're doing subgroup analyses and studies. But there was a subgroup of patients with atrial septal aneurysm and a PFO shunt greater than 20 microbubbles. If they had that in the RESPECT trial, those patients actually did benefit from PFO closure. So sometimes if they have an atrial septal aneurysm, I'll try and ask the cardiologist, how big was the shunt? They don't necessarily track that all the time. I'm going to try and get them to just comment on how big the shunts are in their reports. Actually, I'm going to talk at their next division meeting next month about that. And in addition to getting Holters put on in-house as opposed to having them follow up in clinic. But so that would be the one case where, okay, we can refer them to cardiology for closure. But otherwise, you just really want to do aspirin. There's really no benefit of anticoagulation either. And you guys know PFOs they're present in 20% of the population normally. And in all my experience, granted it's not as much as some of you guys, but in all my experience, I've never had a patient. If you think about it, if it's in 20% of the population, there's a ton of patients out there with stroke that have PFOs, right? I've never had a patient come to me with a stroke and say, oh, I have a PFO. Because you think and that was my old stroke, because you think if you have a PFO and you had a stroke from it before and someone told you that, yeah, you have a PFO, you'd remember that. You have a hole in your heart. Everyone says that, right? But I've only had one patient actually come and say, with their second stroke and say, oh, I have a PFO. And in that patient, we actually found AFib during that hospitalization. So my point is that, it's nice to see a PFO, it gives us a good etiology, but truly, you should really be investigating for AFib in these patients. And like I said, I've only had one patient ever come to me and say, oh, I have a PFO, and that's why I have my stroke. No one ever says that. But people know AFib, they'll know carotid, they say my vessel's blocking the neck, things like that. But no one ever says, oh, I have a PFO, and that's why I have my stroke. Because they'll have a stroke, and the PFO is just an incidental thing, and then you modify their risk factors, you find AFib, and you treat them accordingly. I do always get a lower extremity Doppler or MR venogram on these patients, just because if you do see a PFO, you don't have another etiology. It's just kind of good practice. Basically how I was trained to get these, just to make sure there's no DVT. You don't necessarily have to. It's not really indicated in the guidelines. I just do it just because how I was trained doing it, growing up, and I just think it's good practice just to make sure that they don't have a DVT that went through and caused the stroke. Okay, other rare causes. I'm not going to go through everything, but there's just so you know, there's autoimmune, infectious, hereditary and genetic, connective tissue disorders, mitochondrial, hematologic prothrombotic states, and disorders of the arterial wall. These are very, very rare. You've probably seen it once or twice total. I haven't seen many of these things, and it's my job to look for these things and diagnose them, not necessarily yours. So this leads us to our stroke workup. So what should we be doing in-house? So the first thing I wanted to touch on is that a lot of times what I'm seeing is double orders for carotid ultrasounds and CTAs and MRAs. So just remember, if anyone comes in as an inpatient code neuro and you guys are in the ER admitting them, they're going to automatically get a CTA head and neck, okay? Or if it's a Wakeup, they're going to get an MRA head and neck. So you don't need the carotid ultrasound, okay? Actually, the Wakeup strokes are only getting MRA heads, not the neck, okay? But the inpatient code neuro is the code neuro is less than 6 hours. You're automatically getting a CTA head and neck, so you don't need carotids, okay? And in fact, if a stroke is cortical and it's not in a small vessel disease location, as I showed to you on the MRI before, I always want to get vessel imaging anyways. Why? Because of that one patient that we had a couple of days ago. Without a CTA of the intracranial vessels, I would never have known there's a clot. We had another patient earlier in the week. she had a mid to distal M2 stenosis. And we didn't know because all she had was a carotid ultrasound and MRI brain tissue, no vessel imaging. So she kept having these fluctuating TIA symptoms. She basically go in and out of aphasia is what it was. And we got the vessel imaging. It showed this high-grade stenosis, and we transferred her over to VCU. Now, they actually didn't do a stent because the stenosis was too distal for them to intervene on. But, I mean, we picked it up. We know what it is. We know what's causing her symptoms, and we can medically manage it. I would say if I didn't transfer her over to VCU, I'd do permissive hypertension. I'd probably do a heparin drip and send her to the ICU and just keep her there for 24 to 48 hours. Either heparin drip or dual antiplatelet. I'd figure it out based on kind of other things. But so that vessel imaging is super, super important. So even you probably notice patients already get carotid ultrasounds, but I'll still order the CTA head and neck because I don't want to see just the carotids. Another example, posterior circulation. Then it's not going to be seen by the carotids. If you have a pontine stroke, I want to look at the basilar. I want to look at the verts. I want to see what's going on there. Okay? Do they have like a critical basilar vert stenosis that we need to transfer? Or is it like 50% block where I want to give them dual antiplatelet when they go home? So those things are important. So I think as time goes on, we're going to lean away from carotid ultrasound. The only time I'm okay with just a carotid ultrasound, if it's a classic small vessel disease, stroke, LaCoon, I'm okay with just a carotid ultrasound. That's fine. Because we know it's small vessel disease. Just do the carotid ultrasound to complete the workup, and then we're done with it. And kind of the same thing goes with the cardiac evaluation. If it's a small vessel disease stroke, and it's classic small vessel disease, just the TTE is fine. You don't need to go delving into anything further. But if it's a cardioembolic location, if it's cortical, you're expecting and it's kind of an unusual case, they have fevers, you think you may be endocarditis, you really want to get the TEE. TEE, what it looks at is it looks at the left atrial appendage for clots. You can get puff of smoke, or I should just say smoke, which is spontaneous echo contrast, which is an indicator that you have dilated left atrium and you have a propensity of clot formation there, blood stasis. And it looks at the aortic arch. So it looks for aortic arch atheromas as a potential cause of cardioembolic stroke. Now, I kind of have a soft cutoff of 80 years old for TEE. I usually, if they're above 80, I don't really subject them to a TEE, even if I'm suspecting cardioembolic. I'll just send them home on a 30-day Holter or a loop recorder. The reason is because, TEE is low yield, you guys know. It's normal. I mean, it's normal 90% of the times, 1 out of every 10, probably even less, do you actually pick up something. So I don't really want to subject these patients greater than 80 to that. And also, then you come to the consideration, are they a fall risk? Do they already have dementia? Are we going to even anticoagulate them? So on and so forth. So it's kind of a case-by-case basis. But I have done TEEs and anticoagulant patients in their 90s if their MRS is 0, they're high functioning, they're still out doing yard work and driving and doing everything essentially. I will do that for those patients. And I've given TPA to patients like 95 and above if they're high functioning. Okay. So if you're suspecting cardioembolic, you want to do a TEE, especially if they're less than 80. And also we want to set them up for Holter monitors or loop recorders. So now what we're going to try to do, now I think the way it works is we set them up with outpatient cardiology to fit their Holter. Who knows when that appointment is? Are they even going to follow up? I've had a few patients that come back with strokes that we sent for the Holter. I said, did you get your Holter? They said, oh no, I forgot, or like the appointment time wait was too long, whatever, I didn't have insurance. So now what I'm trying to do is I've talked to Dr. Klimo and Talreja, and they're going to put in implantable loop recorders for us. And what we'll do is we're going to try to set it up that after their TEE, they'll just put the loop recorder in right there if they don't see anything on the TEE, so then they'll be ready to go after that, okay? Now I think Medicare covers loop recorders, but like Blue Cross or Anthem doesn't, so in those cases we'd have to do the 30-day Holters because those insurance companies want to see the 30-day Holter first before you proceed to the loop recorders. So for those cases, I'm going to work with them to see if they can have a tech come and put the 30-day Holter on before the patient gets discharged. I think it'll just be better care for the patient. And that's how it's done at a lot of places where they get get it put on before they go home. And then cardiac MRI. And the reason monitoring is so important is because recent trials of Embrace and Crystal AF, they found that the median time to monitor to find AFib is 80 days actually. And we know the longer you monitor, the more you're going to pick it up, which makes sense. So these loop recorders, especially like the Link device, can stay in up to 3 years. And it's really easy. It's sub-Q right under the skin. We can all it's easy for us to put it in, just like a push of a button, push of a pen. But we just let the cardiologist do it because they're going to monitor it after for us. Cardiac MRI is another thing. We don't really do it here. It's case-by-case basis. I only really resort to using that if the TE is non-definitive. And of course, hemoglobin A1C, lipid panel. So these are things you should all be thinking about in your stroke workup. Most of them are already checked for you. The TE and the Holters aren't. But just think about, has the patient already had CTA head and neck, then we don't need the carotid ultrasound. And think about, is this a classic small vessel disease stroke? Okay, then we can do carotid ultrasound. But is there something weird about it? Could it be cortical? Cortical signs are going to be language involvement, like aphasia, neglect, things like that. And if they have that, or if they have just face and arm involvement and no leg involvement, that's another cortical sign. Then you're thinking like, this could be cortical, or this person has a history of carotid disease or something. Then you just get the CTA, head and neck. Don't waste time with the carotid ultrasound. And if you're unsure, you might as well just do the CTA, head and neck anyways, because 9 times out of 10, I'm going to want that information to help guide treatment. So secondary stroke prevention, cardioembolic, we all know. The staple used to be Coumadin. Now the NOACs have come into use. They're great because we can just give it to them and send them home. We don't need to wait for the INR to get therapeutic. We don't need to bridge them or anything. They actually do better than Coumadin. So in the studies, just kind of briefly, Eliquis and Pradaxa actually were superior to Coumadin. Xarelto wasn't. Xarelto just showed non-inferiority. And all three of them had less of a bleeding risk than Coumadin. These numbers are all statistically significant. Pradaxa and Xarelto actually, though they overall have less of a bleeding risk than Coumadin, for GI bleeding, both of them are more increased than Coumadin. So that's probably why you see us really only do Eliquis now. It's the best one that I like, and I think all the cardiologists like it too, because we know it's better than Coumadin, and it's less bleeding than Coumadin, less GI bleeding, and it's less intracerebral hemorrhage than the other two, which is something I really worry about and I'm concerned about. A couple of the nuances, as you guys know, Pradaxa has a reversal agent, so sometimes patients get really worried because there's no reversal agent. You can offer them Pradaxa, that's fine. Just educate them on the GI bleeding risk. Xarelto is once a day dosing, so patients prefer that as opposed to BID dosing. But I will say that, and I think this is why Xarelto wasn't shown superior to Coumadin and just non-inferior. The half-life of Xarelto is about 9 to 11 hours, around that. And half-life of Eliquis is 5 to 9, which is why it's BID dosing. But I've seen some patients on Xarelto have strokes, and I think it's because it's a daily dosing. Of course, they market it that way to entice patients, but I think you're actually not getting the best coverage because you're not, you'd expect the half-life to be longer if it's a once daily dosing. And so that's just kind of, actually I was taught that by one of my attendings in fellowship, and it made sense to me, and I looked it up, and it's true. Whether that's the actual reason, I don't know, but it's just a theory. So I usually just prefer Eliquis, just because it's better all around in all the avenues. Aortic arch atheroma. So if this is seen, so we know that you have an increased risk of stroke if you have an aortic arch atheroma greater than 4 millimeters. Now what do we do with these? They're rare. I've only really had a couple cases, and usually cardiology is the one that asks me what to do. And it's kind of a patient they do an outpatient echo on or whatever. So you're at increased risk of stroke if it's greater than 4 millimeter plaque. Now what do we do? Do we do antiplatelets, monotherapy? Do we do dual antiplatelet? Do we do anticoagulation? What if the plaque is ulcerated? What if there's a mobile mass? There's really no validated studies. There was the ARCH trial, which compared dual antiplatelet to anticoagulation. There's no statistically significant difference between both. That trial, they just enrolled patients with aortic arch atheromas greater than 4 millimeters. They didn't delineate whether there's ulcerated, there's a mobile mass, what. So kind of what I do, and this is all, it's not evidence-based, it's just kind of what I've been trained and kind of makes physical sense to me, is if there's a mobile mass that's there, I'll anticoagulate, and then I'll re-image in like 3 to 6 months, do re-TEE. If the plaque is ulcerated, or if it's greater than 4 millimeters, I'll do a dual antiplatelet to kind of stabilize it. Otherwise, I'll just do, monotherapy. So, like I said, there's no data on it. It's just kind of how I do it. You're in your right mind to kind of do however you want. But in theory, that stuff kind of makes sense to me. Small vessel disease, we kind of discussed this a little bit. Antiplatelet therapy. I'll get into a little bit about dual antiplatelet, just a couple slides before I finish. Hypertension goal, I'll talk about the SPRINT trial in a second. LDL, as I mentioned earlier, less than 70 or 50% reduction in baseline. We got that from the SPARKLE trial. Hemoglobin A1C, goal less than 7.0, but I always tell patients 6.5 because then they'll achieve the 7.0. Smoking cessation education. Alcohol actually has a J-curve on when you graph it out for stroke risk. So we know that 1 to 2 drinks for men and 1 drink for women is actually beneficial in stroke prevention for ischemic stroke. Once you get more than that, you're at your increased risk for intracerebral hemorrhage and ICH. But that being said, if someone doesn't drink alcohol, I never say that you should start drinking because then you're going to potentially get abuse and everything like that. But if someone drinks 1 to 2 drinks a day, I'm okay with that. And if someone's a heavy drinker, of course, I tell them to cut back. But they sometimes they like this because they're like, oh, I can still drink, and it's beneficial, but I can still cut back. So it's kind of like a happy medium that we usually do between them. Exercise, 30 minutes of moderate intensity, 1 to 3 times a week. Diet, low fat, low sodium, Mediterranean diet. So that's the one diet I usually push with patients. And there's data that it reduces stroke and heart attack risk by 15%. So I always tell patients that. And I kind of give them, the basic gist of what's in the Mediterranean diet, but then usually they'll just go home and Google it and see if they want to do it or not. And then obesity, goal BMI should be 18 to 25. So the SPRINT trial, so I just have 3 trials I just want to go through with you in detail, and then we'll be done. So SPRINT trial came out in 2015. You guys are probably aware, compared intensive blood pressure treatment of goal systolic less than 120 compared to the standard, which is goal less than 140, which is kind of what we've been doing for a while. Goal blood pressure less than 140 over 90, less than 130 over 80 in diabetics. And they wanted to see the effect and if it would have an effect on cardiovascular outcomes. So just kind of how they were able to achieve blood pressure. You can see, with the intensive treatment, patients were on like about close to 3 blood pressure meds. In the standard group, they were on about 2 blood pressure meds. And they did a good job. Within the first year, the mean blood pressure in the standard group was about 136, this is systolic, and the mean in the intensive group was 121, and that kind of lasted throughout the full length of the trial. So I think they did a good job in achieving those goals. And it did actually show a benefit because their primary endpoint was the composite of CVD events. MI, non-MI ACS, stroke, heart failure, cardiovascular death. And they found those to be 25% lower in the intensive group compared to the standard group, and all-cause mortality was reduced by 20%. They actually stopped the trial early because there was a benefit. They stopped it after 3 years because there was a benefit in these patients. And the good thing is that they were able to achieve that goal in the trial of the 136 and the 121. So there was a difference, the treatment effect was similar. There's 6 pre-specified groups of interest where I think age, race, so greater than less than 75, African American, non-African American, and GFR were the other 2 things. I think above 60 or something below 60. And the number needed to treat to prevent a primary outcome or death was 61 for the 1 in 61 for the primary outcome, and 1 in 90 for death. So those are pretty good, not great. You know, you like to have like a 1 in 3 or 1 in 5, but that's still good. If you think about it, when we give aspirin, the number needed to treat for aspirin is like 1 in 100. I don't know if you guys knew that, but we do it, right? And it's like standard of care. So this is actually better than that. Now there was some concern about, and it's probably because they're on a couple more blood pressure meds, probably more ACE inhibitors and diuretics. Patients did have bumps in creatinine in the more intensive treatment group. And of course there's side effects, and there was less compliance with the intensive treatment because of orthostatic thing, hypotension, and so on and so forth. So those are obviously also a consideration, and I'm not saying this intensive 120 over 80 is for everybody, but I think for someone with no other real risk factors, especially no kidney disease, and that this is something that we should try to strive for. Mainly because, you know, it's kind of one of those things that I alluded to with the hemoglobin A1C. If you tell them 120, they'll get to 130 and they think they're okay, you know. But if you tell them 140, then they'll be at 150, 160, and they're like, oh, I'm fine, I'm close enough, you know. So I think if anything, that's the main reason I always tell them 120, because I know if when they're at 130, mid 130s, they're still thinking they're okay, you know, and I'm okay with that. I'm okay with that. Large artery athero. For carotids, you know, symptomatic versus asymptomatic. So based on the NASCET trials, you know, we treat if they're greater than 70% stenosis and symptomatic. If they're symptomatic between 50 and 69%, there's still argument in the data. So in the NASCET trials, 50 to 69% symptomatic stenosis was actually positive, in that you should take them for CEA. But those trials back then, you know, the dual antiplatelet regimen wasn't good. Statins weren't even around, okay? So the consensus is now is that we need to reinvestigate, which is what they're doing now with trials. There's like a CREST-3 trial, which compares symptomatic to asymptomatic. It compares 50 to 69% to 70% and greater. It compares symptomatic to asymptomatic, 50 to 69%, and it looks at asymptomatic, 70% or greater. It also looks at comparing CEA versus stent. And they're enrolling patients, and we'll see what those results show. But for now, what I do is if it's greater than 70% and it's symptomatic, I refer them to cardiology, to vascular surgery for CEA, or stent, depending on the patient population. If it's symptomatic 50 to 69%, I do medical management and I track. So I'll do dual antiplatelet, high dose statin, blood pressure goal 120 over 80, hemoglobin A1C less than 6.5, and I re-image in 3 to 6 months in clinic. And if it's stable, then we're good. But if it starts creeping up to 70, 80%, and I know they've been compliant, then I'll refer them for CEA. And if it's asymptomatic greater than 70%, I just medical management. I don't refer. Okay, but I will track. I'll track those as well. And where do we get this medical management from? We get it from the Sampras Trial, which I'll talk about on the next slide. But the Sampras Trial and the VAST Trial were two big trials that looked at intracranial stenting and vertebral artery stenting, showed no benefit, actually showed inferiority of stenting. So we definitely don't recommend intracranial stents now. And aortic arch atheroma, I just touched on it on the previous slide. Remember, there's no validated studies. So how do we get to dual antiplatelet therapy? You guys probably see me a lot doing dual antiplatelet for 3 months and then switching to mono and so on and so forth. So it started with the Sampras trial. You know, they compared aggressive medical management to stenting for patients with acute ischemic stroke, or TIA. And as you can see, the medical management group did far better than the stenting group, way, way better, that they actually stopped the trial early because they were doing harm to these patients that were getting stents. Now, what was the medical management? It was aspirin 325 daily, and it was Plavix daily for 3 months. And then after that, you switch to monotherapy. The systolic blood pressure goal was less than 140 and less than 130 if diabetic. LDL target was less than 70, and the target hemoglobin A1C was less than 7. Non-HDL cholesterol is less than 100. Smoking cessation education, weight loss, exercise. This is, as you guys know, it's really hard to have our patients do. How they did it in this trial was actually good. I mean, if we had more resources in this country and just in general, we could do this, but they had literally someone call them every week to make sure they're taking their medications, measuring their blood pressure, and make sure they're doing all these things. So it was a really, really good way of doing it. And I think, and the goal is if you can achieve that, then of course the patients will do better. But of course, non-compliance is a big thing in our patient population, or just patients in general. So this is where the first thing of dual antiplatelet came about, because people realized, wow, this actually could be a really good beneficial treatment. We've never really investigated this before. So what happened next? Next was a chance trial. This was a randomized controlled trial in China that compared dual antiplatelet for 3 weeks after acute ischemic stroke or TIA to just monotherapy or placebo. And they did show a benefit in the primary outcome of stroke, ischemic or hemorrhagic, but this was China. As I mentioned before, they all have intracranial athero. What do we have in the US? We have AFib. So it doesn't really translate well to our patient population. We're not sure if it works or not. But, theoretically it worked in the Sampras trial, so I still do it. And, where I've trained, we still do dual antiplatelet in specific cases. And this is just the results of the chance trial. You can see dual antiplatelet versus aspirin alone. There was a benefit in terms of survival risk of stroke. So the POINT trial, and this is the last slide. The POINT trial is a trial that is ongoing in the US right now. We actually were enrolling patients when I was in fellowship. And stands for platelet inhibition and UTI and minor stroke, randomized double-blind. It basically compares Plavix plus aspirin to aspirin alone. So what they'll do is if you come in and you're within 12 hours of your TIA or stroke, and you don't get TPA or anything like that. Actually, no, you can still get TPA. You can still get TPA. But if you come in within 12 hours, you get a loading dose of 600 milligrams Plavix, and then you go home on dual antiplatelet or placebo. The placebo being if it's Plavix or placebo or not. And anecdotally, we had some good outcomes for what we think patients were on the Plavix and not the placebo. Obviously, we have to wait for the results to be published and see what the data showed. But they have the patients take it for 3 months and then switch to mono. So that's kind of where I get my 3 months therapy and switch to mono. So when do I do that? Is, like I said, there's no formal guidelines yet. It's just kind of based on studies and taking different patient subgroups and kind of seeing what they did. There's been no trial design until the POINT trial to actually investigate this specific question. But what I do is if they have carotid stenosis greater than 50, doesn't matter if it's symptomatic or asymptomatic, I'll do a dual antiplatelet. Then I'll do the high-dose statin, blood pressure goal, smoking cessation education, all that stuff. If they have intracranial athero, I'll do it. So like that lady that we had with the A3 stenosis, I'm going to send her home on dual antiplatelet. If they have basilar disease, if we don't have a good etiology for their stroke and they're technically cryptogenic, but I see tons of intracranial athero on their MRA or CTA, I'll do dual antiplatelet. Okay. For the carotids, I'll probably do dual antiplatelet indefinitely, unless by some weird miraculous encounter that it goes from 50% to less than 50, then I'll probably stop it. But I'll probably do it indefinitely until the patient kind of feels comfortable. If the patient wants to come off it, I'm okay, maybe after 6 months to a year. If it's small vessel disease and they're already on monotherapy, a lot of times what I'll do is I'll do dual antiplatelet and then switch to mono after 3 months. So I'll tell them, you were on aspirin, do aspirin Plavix for 3 months, then switch to Plavix, or you can go back to aspirin. There's really no data, but we like to see that we're doing some benefit for our patients. So, after the 3 months of dual, we can switch to Plavix because they've technically maybe are an aspirin failure if they're compliant. Sometimes people will go from aspirin baby to 325, even though there's no data to show that 325 is better than 81. It just shows that there's increased risk of bleeding. So that's kind of what I do, and it's just like a case-by-case basis. And I know I talked to you guys that I don't have a clinic, but I'm actually just going to start doing like a half day of clinic a month just to basically follow these types of patients. They're rare, but I'll follow them and then probably re-image and just to see how they're doing, and making sure they're compliant and so on and so forth.